Welcome to the Deep Dive. Today we're plunging into a really complex but absolutely vital area of medicine. Diseases that affect the aortic arch.
That's right. Think of the aortic arch as that critical curve at the top of your body's main artery. It's, where blood gets distributed up to your head and arms before heading south. When something goes wrong here, it's serious business, and the solutions are incredibly intricate.
They really are. And our mission today is to try and cut through some of that complexity for you. We've been digging into a major expert consensus document.
A big one.
Yeah, a joint effort from leading cardiac and vascular surgeons across Europe, reviewed internationally. It's a heavy piece, packed with detailed recommendations.
Absolutely dense. But the goal here isn't to read you the textbook, right?
Not at all.
It's more to pull out the most important insights, the maybe surprising facts, and the key considerations that these experts agree on. Like, what do they really want doctors treating this to know? What are the core challenges? We want to give you a clearer picture without getting totally lost in the weeds.
Exactly. So let's talk about this critical piece of anatomy first. To even discuss the problems here, doctors need a map, basically.
They do. The experts use what are called the Ishimaru zones. Think of them as numbered segments along the aortic arch, starting from zone 0 right at the beginning, near the ascending aorta, and going out to zone 4 in the descending part. It just gives everyone a common language, to point to specific areas.
Makes sense. And I saw they talk about different shapes the arch can have.
Yeah.
Types 1, 2, and 3.
Yes, exactly. The aortic arch configuration, it's classified based on how high up the first major branch, that's the innominate artery, originates relative to the top of the curve.
So type I is high, type 3 is low.
Correct. Type 2 is kind of mid-level. And this isn't just academic detail. The specific anatomy significantly influences what kind of treatment is even possible, what approach they can take.
So the individual plumbing really matters for the fix. Okay. Now, the main problems we hear about are bulging, that's an aneurysm,
right,
and tearing, which is a dissection.
Precisely. And the document points out that isolated arch aneurysms, ones just in the arch, are actually quite rare.
Oh, really?
Yeah, they often extend from problems either in the ascending aorta coming up from the heart or the descending aorta going down. Dissections, though, they're a major focus, a big concern.
And when the aorta tears like that, the language, the terminology for describing it sounds critical.
Absolutely vital. The experts really emphasize standardizing the terms. Where exactly did the tear start? How's blood moving between the layers? Where does it end? It's all about clear communication, especially in these high-stakes situations.
Yeah, you need everyone on the same page. And the timing of a dissection is also key, isn't it? They break it down into phases.
Yes, they define it by how much time has passed since symptoms started. So acute is within the first 14 days.
Okay.
Subacute is from 15 up to 90 days. And chronic is anything after 90 days. And the management strategies can differ quite a bit depending on which phase a patient is in.
Right. And the classifications are Stanford type A and type B.
Those are the main ones. Type A involves the ascending aorta, that first part coming out of the heart. That's always a surgical emergency.
Always.
Type B is limited to the descending aorta, the part going down the chest, usually starting after the left arm artery branches off. But the document also highlights this non-A, non-B category.
Non-A, non-B.
Yeah, where the dissection involves the arch itself, but crucially, it spares the ascending aorta. It's a less common pattern, but really important to distinguish for treatment.
Got it. What makes a dissection complicated? That sounds like it adds another layer of danger.
It absolutely does. A dissection becomes complicated if it causes immediate severe problems. This could be rapid expansion of the aorta itself or rupture.
Okay, like it's about to burst.
Exactly. Or critically malperfusion, which just means blood flow to vital organs or the limbs or even the spinal cord is being cut off by the dissection flap.
That sounds bad.
It is. Also, pain that can't be controlled or really high blood pressure that won't come down. For type A or that non-A, non-B type, other complications include blood pooling around the heart, a sudden leak in the aortic valve, or lack of blood flow to the heart muscle itself or the brain.
So it's not just the tear itself, but the immediate effect of the tear on the rest of the body that makes it complicated.
That's the key distinction.
Yeah.
They also mention intramural hematoma, IMH.
Right, IMH. What exactly is that?
Think of it like a bruise deep inside the wall of the aorta. Blood pools there, causing the wall to thicken, but there isn't a clear, visible tear connecting the inner channel to this bruised area.
So no obvious flap.
Right. It can look similar to a dissection on scans, though, and it's often considered a kind of precursor, something that might develop into a full dissection later.
Like a potential warning sign.
Okay.
And penetrating aortic ulcer, PAU.
That's more like an ulceration, often starting over some fatty plaque buildup inside the aorta that burrows into the wall. It's linked to widespread atherosclerosis, hardening of the arteries.
And it can lead to worse things.
Yeah, it can also lead to an aneurysm forming there, or an IMH, or even a full dissection. The experts say intervention is needed if it's causing persistent pain, if it's growing fast on scans, or if it actually ruptures.
And if it's not causing symptoms.
Even then, size matters. They suggest that PAUs bigger than about 20 millimeters wide, or with a base wider than 10 millimeters, are probably at higher risk of progressing and causing trouble later.
These sound like dynamic, pretty unpredictable problems. How well do we actually understand their natural course? Like, what happens if they're just left untreated?
That's a really fascinating point the document makes. There actually isn't a dedicated long-term study specifically looking at just arch disease progression on its own. A lot of the data is sort of extrapolated from studies on ascending or descending aorta problems. And here's something I found really interesting. Diameter alone isn't the sole predictor of whether a dissection will happen.
It's not just about size.
Not entirely. Get this. The aorta can actually increase in diameter by about 30% at the moment of dissection compared to scans taken before the event.
30%? Wow, that's a big jump. So just watching the size isn't necessarily enough to predict the tear?
Exactly. It tells you there's more going on dynamically than just slow expansion. Although, naturally, larger aneurysms do tend to grow faster over time. That part holds true.
Okay. Are genetics a big part of the story here? We hear about Marfan syndrome.
Definitely. Marfan is the well-known one, but the experts really highlight another condition called Loeys-Dietz syndrome, or LDS.
LDS, what's critical about that one?
What's critical is that patients with LDS can have that tear at much smaller aortic diameters than doctors previously thought were risky, even smaller than the thresholds used for Marfan patients.
Really? So the safe size is different depending on the genetics?
It seems so. Identifying these genetic links is huge. It's not just for guiding the patient's own treatment, but it's vital for screening and advising their family members too.
Right, it becomes a family issue. And speaking of anatomy and risk, you mentioned they found a specific arch pattern linked to problems.
Yes, this was another really intriguing finding cited in the document. A specific anatomical variation. It's where the innominate artery and the left common carotid artery share a common origin point off the arch. Sometimes called a bovine arch pattern, though that term isn't perfectly accurate.
Okay, so two major branches coming off together.
Right. And this pattern was linked, in one particular study they referenced, to a significantly higher rate of tears actually starting in the arch itself, and also a higher rate of neurological issues, like stroke, after surgery for type A dissection.
Wow. So a subtle difference in how those major pipes come off the main curve can dramatically change both where the problem starts and the risk during the fix.
It raises exactly that question. How do these subtle anatomical variations influence vulnerability? How do they impact the challenges of repair? It's a key area.
It really underscores the complexity, doesn't it? Okay, so we've talked about what can go wrong and some of the underlying factors. How do doctors actually figure out exactly what's happening inside the aorta?
Well, imaging is absolutely paramount. It's the cornerstone of both diagnosis and planning the treatment.
And the go-to seems to be CT scans, right? CT angiography.
Yes, CTA is the recommended first line. The experts give it a strong Class I recommendation. Why? Because it's fast, which is obviously vital in emergencies.
Crucial.
And it gives incredibly detailed 3D images of the aorta and all its branches. Really lets you see the structure.
How do they get such clear pictures, especially with the heart beating?
Well, they inject a contrast dye that helps the vessels show up clearly. Then they scan from the chest, usually down to the legs. To handle the challenge of the heart beating and causing motion blur, they use techniques like timing the scan with the patient's ECG, their heart rhythm, or they use newer, very fast CT scanners. And for accurate planning, especially before surgery, measuring the aorta's diameter isn't just drawing a simple line on the image. It has to be done very precisely using what they call double oblique views.
Double oblique?
Yeah. It means digitally slicing the 3D image so you're looking perfectly perpendicular straight across the vessel relative to the direction of blood flow. That gives you the true diameter and not an overestimate from an angled cut.
That precision sounds really important for deciding on treatment. What about MRI? It offers different kinds of detail, doesn't it?
MRI is fantastic for looking at soft tissues. It uses no radiation, which is a plus, and it can actually show blood flow patterns dynamically over time.
So you can see how the blood is moving.
Exactly. Its main drawback, especially in an emergency, is that it just takes longer to perform than a CT scan. But for detailed analysis outside of that acute setting, it's invaluable. The experts actually call time-resolved MRA, which captures images throughout the cardiac cycle, the gold standard for seeing how dissection membranes flap and move, and for distinguishing the true channel from the false channel.
Wow, the gold standard for seeing the dynamics. That's incredible. Any concerns with the contrast dye used in MRI, the gadolinium?
There have been some concerns raised, yeah. Particularly in patients with kidney problems, there was a risk of a condition called NSF, though that's much rarer now with newer contrast agents. There's also been discussion about gadolinium depositing in the brain over time with repeated scans.
Okay.
The document notes these concerns, but adds that, based on the source material they reviewed, clinical symptoms specifically linked to that brain deposition haven't really been described. So it's something people are aware of, but the clinical impact isn't clear yet.
Understood. What about ultrasound? That seems maybe less powerful overall, but it's quick and portable.
Right. Ultrasound, particularly transesophageal echo, or TOE.
That's the one down the throat.
Yeah, the probe goes into the esophagus right behind the heart and aorta. It has a smaller field of view than CT or MRI, obviously, but it gives very high-resolution, real-time images and blood flow information. TOE can be done right at the bedside or, crucially, in the operating room during the procedure.
So it's used during the fix.
Very commonly, yes. There's also intravascular ultrasound, IVUS, where a tiny probe goes inside the blood vessel on a catheter. That's invasive, obviously, but gives amazing dynamic views from inside during a procedure. And standard ultrasound is also useful for quickly checking the vessels branching off the arch, like the carotids in the neck.
So it's really a suite of imaging tools used strategically depending on the situation. Emergency versus planned, diagnosis versus procedural guidance.
Exactly. You use the right tool for the job.
How does the full diagnostic workup look then? Especially before a big planned procedure. It sounds like more than just one scan.
Oh, absolutely. In a true emergency, like an acute type A dissection, it's rapid. Usually just enough imaging, a quick CTA, maybe a TOE in the oar to confirm the diagnosis and get straight to surgery.
Makes sense.
But for comprehensive planning, especially for elective cases, it's a much broader picture. They recommend a standardized approach. You need to evaluate the heart itself, especially the valves, using echo, TTE or TICO. You need to check the coronary arteries for blockages, especially if open heart surgery is planned. You need to assess those major vessels coming off the arch, often with ultrasound. And, crucially, they strongly recommend assessing the cerebral crossflow and the patency of the circle of Willis. That's the network of arteries at the base of the brain.
Why is checking the brain's plumbing so important?
Because procedures on the aortic arch carry a risk of temporarily or permanently disrupting blood flow to the brain. Checking the circle of Willis beforehand tells the team if the patient has good natural backup routes, good collateral circulation. It's critical for predicting and potentially mitigating stroke risk during the procedure.
Okay, that makes a lot of sense. Assess the backup systems before you potentially interrupt the main supply.
Precisely. And you also generally need a CTA of the entire aorta, from chest to legs, to see if there are any other problems lurking elsewhere that might affect the plan. All these findings, the heart, the coronaries, the arch branches, the brain circulation, the rest of total aorta, all get synthesized to guide the final treatment recommendation.
It's a truly multidisciplinary assessment then, looking at the whole patient, the whole system. Which brings us neatly to the decision-making itself. Who makes these incredibly complex choices about what to do?
Yeah, this is a core principle emphasized throughout the document. Decision-making for aortic arch pathologies should absolutely be led by a dedicated, multidisciplinary aortic team. This gets a strong Class I recommendation based on expert consensus.
And what kind of specialists make up this aortic team?
It's typically led by cardiac surgeons and vascular surgeons working closely together. But essential input comes from anesthesiologists, cardiologists, radiologists, the imaging experts, and often geneticists as well, especially if inherited conditions are suspected.
And why is that team approach considered so critical here? It sounds like more than just getting a second opinion.
Oh, it's much more than that. Because these problems are so complex, and the treatment options, open surgery, endovascular hybrid, vary so widely in their risks and benefits for different patients. You need all that expertise at the table. The surgeons, for instance, bring that unique experience of linking what the scans look like to what the aortic tissue actually feels like and handles like during surgery. That tactile feedback is vital for choosing between open and endo approaches sometimes.
Right. The scan doesn't tell you everything about tissue quality.
Yeah.
And where these procedures happen also seems critical. They talk about centralization.
Absolutely. The experts strongly recommend centralization of care, particularly for planned elective procedures. This means these complex arch repairs should ideally be done in specialized centers.
Specialized how?
Centers that have both experienced open cardiac and vascular surgery teams and dedicated expertise and technology for advanced endovascular techniques, all available on-site 24/7.
Why is having both open and endo capability in one place so important?
Because these conditions are relatively rare, they're highly complex, and you need the full range of potential backup plans and expertise immediately available. The document argues that only in these high-volume, specialized centers can the teams truly understand the long-term behavior of these diseases, realistically offer every possible treatment option tailored to the patient, and effectively manage the potentially serious complications that can arise.
So volume and breadth of expertise matter.
Yeah, there's growing evidence suggesting a correlation between the number of complex aortic procedures a center performs, the volume, and better patient outcomes. Experience seems to count.
Okay. So get treated by an experienced team in a center that does a lot of these and has all the tools. And what about after the treatment? Is that the end of the story?
Definitely not. Continuous follow-up is also strongly recommended. This isn't just a quick checkup. It's needed both before someone meets the criteria for treatment, to monitor progression, and certainly after treatment.
Why the long-term follow-up?
Well, partly for quality control to ensure the repair is holding up, but also because the underlying disease process might affect other parts of the aorta over time. You need to watch for potential new problems developing in aortic segments that weren't treated initially. It's about long-term patient health and surveillance.
Makes sense. The aorta is one long continuous structure after all. You mentioned diameter earlier. Is there a general rule of thumb, like a size threshold, for when they consider surgery for an arch aneurysm?
For an isolated aortic arch aneurysm, one just confined to the arch, the experts suggest that surgery should be considered when the diameter reaches 55 millimeters. That's about 2¼ inches.
55 millimeters.
But, and this is really important to reiterate, based on our earlier points, diameter is definitely not the only factor. Other things like how fast it's growing, whether the patient has symptoms, or if they have an underlying genetic condition like Marfan or LDS, all play a huge role in the decision. 55 millimeter is a guideline to start considering, not an absolute trigger.
Right, it's just one piece of a much larger risk assessment puzzle. Okay, so the specialized aortic team in the centralized center has done the workup, assessed the risks, and made the decision to intervene. The procedure itself sounds incredibly delicate, especially with the brain and spinal cord so nearby. How do they keep patients safe during the actual repair?
That's a massive focus, as you'd expect. Protecting those vital organs, especially the brain and spinal cord during aortic arch repair, is a major challenge and requires sophisticated monitoring.
You mentioned TOE, the transesophageal echo, earlier. Is that used routinely during the surgery itself?
Yes, TOE is strongly recommended during all open thoracic aortic surgical procedures, and the guidelines say it should at least be available during hybrid and endovascular procedures too. It gives the surgeons and anesthesiologists real-time pictures of the heart function and the aorta right there in the operating room. Invaluable.
Okay. What about monitoring blood pressure? Is one line enough?
Standard invasive arterial pressure monitoring is essential, of course, but for open arch surgery, the experts recommend considering monitoring pressure in both arms, not just one.
Both arms. Why?
To ensure you have continuous, reliable monitoring of the pressure going to the brain, especially if one side might be affected by clamping or cannulation during the procedure, they also suggest considering monitoring pressure in the femoral artery, down in the leg.
And the leg pressure tells you.
It often gives a better reflection of the central aortic pressure during and after bypass, and it helps detect any significant pressure difference across the repair site once it's done. So, multi-site pressure monitoring gives a more complete picture.
That makes sense, catching any potential flow issues early. What about brain function or oxygen levels, more specifically? How do they watch that?
Monitoring brain oxygenation directly using near-infrared spectroscopy, or NIRS, is recommended during surgery for aortic arch repair. It uses sensors on the forehead.
NIRS.
Yeah, NIRS. It helps detect if the brain's oxygen levels are starting to drop too low during critical parts of the operation. And importantly, centers should have a clear plan and algorithm for how to react if those NIRS readings do fall. There's evidence linking low brain oxygen levels during surgery to new neurological problems afterwards.
So it's another early warning system to potentially head off a serious problem like stroke. Are there other ways they monitor the nervous system electrically?
Yes, electrophysiological monitoring can be used. Things like EEG to monitor brain electrical activity that can help confirm deep suppression during certain techniques like very deep hypothermic circulatory arrest. And then there's MEP and SSP monitoring.
MEP and SFP.
Motor-evoked potentials and somatosensory-evoked potentials. These monitor the electrical pathways of the spinal cord. They can be useful for detecting spinal cord ischemia, lack of blood flow, particularly when surgeons are covering long segments of the descending aorta with a graft or stent. Their selective use may be considered, but the experts classify this as lower-level evidence or opinion-based, often depending on the specific patient risk and the complexity of the planned procedure.
So more tools in the toolbox used selectively. Spinal cord ischemia is obviously a huge fear with these operations. Is there anything else they do proactively to try and prevent that?
Yes. Lumbar cerebrospinal fluid drainage, CSF drainage, is something that is considered.
Draining spinal fluid, how does that help?
The idea is that draining some CSF from around the spinal cord lowers the pressure within the spinal canal. This might improve the pressure gradient driving blood flow to the spinal cord, potentially protecting it during periods of reduced aortic flow. It's considered particularly in high-risk patients or when using techniques like the frozen elephant trunk or extensive TEVAR that cover a lot of the descending aorta.
So maybe used proactively in some cases.
Yes, proactively considered. And if a patient unfortunately develops signs of spinal cord injury after the surgery, then putting in a CSF drain is strongly recommended as part of the immediate treatment bundle.
I see. Are there specific pressure targets they aim for with the drain?
Yes. Typically, they aim for CSF pressures around 10 to 12 mmHg normally, or maybe a bit lower, like 8 to 10 mmHg if spinal cord symptoms actually occur. They do note there's a small risk, maybe around 1% of complications from the drain itself, like bleeding or overdrainage.
Understood. Okay, what other monitoring is absolutely key during these big open surgeries?
Temperature monitoring is critical, and not just in one place. Multi-site temperature monitoring is indicated measuring core temperature, at least in the nasopharynx, back of the nose, tympanic membrane ear, and bladder or rectum.
Multiple sites for temperature.
Yes, because different parts of the body cool and rewarm at different rates. Monitoring multiple sites, especially brain-related ones like the nasopharynx or tympanic membrane, is vital for ensuring adequate and even cooling and warming, particularly when using hypothermic circulatory arrest techniques to protect the brain and other organs.
Right, got to make sure the brain is protected properly.
Yeah.
And blood clotting must be a constant balancing act during these long, complex operations with bypass.
Absolutely. Managing coagulation is crucial. Using point-of-care tests like the activated clotting time or ACT to monitor the effects of heparin is the minimum standard. But more advanced viscoelastic tests like TEG or ROTEM.
TEG or ROTEM.
Yeah, thrombolithography. These give a more comprehensive picture of the whole clotting process, clot formation, strength, breakdown. They're considered beneficial during open surgery with bypass, as they can help guide decisions about giving blood products like platelets or plasma more precisely. The goal is to manage bleeding effectively and potentially reduce the overall need for blood transfusions, which carry their own risks.
It's clear that the monitoring during these procedures is incredibly sophisticated, just layer upon layer, aiming to protect the patient every single step of the way. Okay, let's shift gears slightly and talk about the actual repair strategies themselves. The document lays out the main options: open surgery, hybrid approaches, and purely endovascular techniques.
Right, and the exciting thing is that the treatment options have really expanded over the years. There are now solutions, or at least potential solutions, for patients who, in the past, might have been considered too high risk for any kind of traditional surgery.
So starting with the traditional gold standard, open aortic arch replacement.
This is the classic approach. It involves surgically replacing the diseased arch segment with a synthetic fabric graft, usually Docrin, through an incision in the chest, often a sternotomy down the middle. It's frequently combined with techniques like the standard elephant trunk or the frozen elephant trunk, especially if there are issues extending down the aorta.
Elephant trunk. That name always sounds so dramatic. Can you explain that standard one again?
It's a bit visual, isn't it? The standard elephant trunk technique involves leaving an extra segment of the fabric graft hanging down, unattached, inside the descending aorta beyond the main arch repair.
Why leave it hanging?
It's typically used when you anticipate needing to do further surgery on the descending aorta later on. Maybe there's an aneurysm lower down that needs fixing in a second stage. That dangling graft provides a really stable, easy-to-SOTA landing zone or clamping site for the next operation. It simplifies the second procedure.
Ah, okay. Like deliberately setting up the second stage during the first surgery.
Exactly. An interesting technical point the document mentions is that when using a standard elephant trunk, delivering blood flow forward during bypass, usually via an artery in the arm, like the right subclavian or axillary.
Antegrade perfusion.
Right, antegrade perfusion is generally recommended over delivering blood flow backwards from the femoral artery in the leg. Retrograde perfusion. This is to avoid potentially obstructing the openings of the arch vessels with the bypass cannula or disturbing plaque. They also mention removing the dissection membrane where the trunk goes in, and often preferring to sew the distal connection, the anastomosis, and zone 2 of the arch for easier access and better bleeding control.
Lots of technical details there. Okay, then there's the frozen elephant trunk, or FET. You mentioned this blends open and endo principles.
It does, and it's become a really key technique in the toolbox. With FET, a special hybrid prosthesis, basically a standard fabric graft sewn to a covered stent graft, is used. During the open arch replacement, this device is deployed down into the descending aorta through the opened arch.
So the stent part goes down into the descending aorta.
Correct. The fabric graft part is sewn into the arch repair like normal, but the attached stent graft extends down and expands against the wall of the descending aorta. It's fixed in place surgically with sutures at the top. This provides an immediate seal, which is particularly effective in dissections for closing off the false lumen, promoting thrombosis, and remodeling the aorta.
So it treats the arch and the top part of the descending aorta in one go.
Pretty much. And importantly, that stent graft portion also serves as an excellent ready-made landing zone for any potential future endovascular stent grafting, TEVAR, that might be needed further down the descending or thoraco-abdominal aorta later. It simplifies future interventions.
That sounds very useful. When do the experts recommend considering using aorta?
It's considered a good option in acute type A dissections, especially if the main tear is located in the distal arch or the proximal descending aorta, or if there's malperfusion that needs addressing downstream.
Okay.
It may also be considered in type A dissections simply as a strategy to help prevent the downstream aorta from dilating into an aneurysm later on a common midterm problem.
Prophylactically, almost.
Kind of. It's also considered for complicated acute type B dissections if a purely endovascular fix isn't possible or fails. And it's considered beneficial for patients who already have significant disease further down the thoracic or thoraco-abdominal aorta that is likely going to need treatment later anyway. It sets up that future repair nicely.
Makes sense. What about using these stent grafts, even the FET type, in patients with genetic connective tissue diseases? Is that still okay?
That remains somewhat controversial. The tissue quality in conditions like Marfan or Loeys-Dietz is inherently weaker. While FET is sometimes used, the experts generally recommend caution, particularly avoiding oversizing the stent graft component significantly, as that could potentially damage the fragile aortic wall.
So careful sizing is key.
Yes. And they also stress the need to critically evaluate the situation before deploying an FET if a patient's vital organ blood supply in a dissection totally depends on flow through the false lumen. You have to be sure there are adequate communications or re-entry tiers further down to allow blood flow back into the true lumen before you potentially obliterate the proximal false lumen entry with the FET.
Right. Don't want to inadvertently cut off blood supply. Okay, so FET is a powerful combined open endo technique. What about the other main category of hybrid arch repair, the one involving debranching first?
Right, this is a different philosophy. Here, the main open surgical part is focused on debranching the major vessels that come off the arch, the innominate left carotid, left subclavian arteries.
Debranching means?
It means surgically rerouting them. Typically, bypass grafts are created, often originating from the ascending aorta, and sewn end to side onto these major arch vessels. This effectively moves their origin point off the native diseased arch.
So you move the pikes first.
Exactly. Once the head and arm vessels are safely supplied by these bypass grafts, the surgeon can then deploy a standard thoracic endovascular aortic repair stent graft, or TEVAR, from inside the vessel to cover and exclude the diseased native arch segment, landing the stent graft proximally in the healthy ascending aorta, or the new graft there, and distally in the descending aorta.
And the big advantage here is?
The potential main advantage is avoiding the need for deep hypothermic circulatory arrest, that period of profound cooling and stopping blood circulation that's often required for complex open arch replacements. By keeping the brain perfused via the debranching grafts, the hope is to reduce the physiological stress of the operation, which might be beneficial for certain higher-risk patients, perhaps older or more frail individuals.
Okay. Potentially less invasive physiologically. Any downsides?
Well, it's still major surgery with the debranching component, and interestingly, the document notes that this hybrid debranching plus TEVAR approach may actually carry a higher risk of stroke compared to standard open repair in some high-risk patient groups.
Higher stroke risk. Why would that be?
Possibly due to the manipulation required on the arch and the origins of the great vessels during the debranching phase, which could dislodge atherosclerotic debris. Also, deploying the large TEVAR graft itself carries stroke risk, so it's not necessarily a universally lower risk option, especially neurologically.
That's an important nuance.
Yeah.
Are there specific areas of the arch where this hybrid stenting after debranching is typically considered?
Yes, the guidelines say TAVR landing in zones 1 and 2, that's the sort of mid to distal arch after appropriate debranching, is considered a reasonable option in patients with suitable anatomy.
Okay. What about landing in zone 0, right near the ascending aorta?
Using TEVAR in zone 0 after debranching may be considered, but generally only in patients deemed unfit for a full open repair, again, provided they have suitable anatomy for the stent graft to land securely. It's seen as more of a bailout or high-risk patient strategy.
And that left subclavian artery comes up again here, doesn't it? The one supplying the arm and potentially the spinal cord.
It certainly does. To reduce the risk of neurological complications, both stroke and spinal cord ischemia, the experts recommend that preventive revascularization of the left subclavian artery, LSA, should be considered before elective TEVAR that plans to cover its origin in zones 0, 1, or 2.
So basically bypass the LSA first if you're planning to cover its opening with the stent graft.
Yes, consider doing that proactively, especially in elective cases, because that artery can be a critical supply line not just for the left arm, but also via the vertebral artery to the brain, and importantly, potentially to the spinal cord's blood supply network. Covering it without ensuring adequate collateral flow can be risky.
Got it. Secure that supply line first. Are there clear situations where this hybrid debranching TEVAR approach is not recommended?
Yes, the landing zones for the TEVAR graft are critical. If the healthy segment of aorta where the graft needs to seal is too short, generally less than 25 millimeters, or if the aorta there is too wide, over 38 millimeters in diameter, TEVAR is generally not recommended due to the high risk of the graft not sealing properly or migrating.
Too short or too wide is bad.
Exactly. Also, similar to FET, using TEVAR in zones 0 to 2 is not recommended in patients with connective tissue disease if the planned landing zone is in their native diseased aorta due to concerns about the durability and safety in fragile tissue.
Okay. And who is still probably best suited for the purely open repair despite these hybrid options?
The guidelines suggest that traditional open repair should be considered the preferred approach in patients who also need concomitant heart valve surgery, like aortic valve replacement, which requires opening the heart anyway.
Makes sense to do it all at once.
Right. And also in patients considered to be at high risk for developing a retrograde type A dissection, that's where the dissection tears backwards from the stent graft into the ascending aorta. This risk is thought to be higher in patients with an already enlarged ascending aorta over 38 millimeter, those with a bicuspid aortic valve, or those with certain challenging arch shapes. Open repair might be safer for them. And again, just to emphasize, complex hybrid aortic arch repair should really be centralized in those high-volume centers with established expertise in both open and endovascular procedures.
Okay, so we have open surgery, sometimes with an elephant trunk. We have hybrid approaches like FET or debranching plus TEVAR. What about fixing the arch entirely with just stent grafts, with no major open surgery at all? The total endovascular arch repair.
This is really the cutting edge, the most technically demanding frontier currently. The goal here is to repair the aortic arch completely from the inside, using catheters and specialized stent grafts delivered through arteries, usually in the groin or arm, completely avoiding the need to open the chest.
Wow. That sounds incredibly difficult given the sharp curve of the arch and all those critical branches coming off right there.
It is technically very challenging. It requires highly specialized stent grafts that have either pre-manufactured holes, called fenestrations, or built-in side tubes, called branches. These fenestrations or branches have to be meticulously positioned during deployment to align perfectly with the patient's own individual origins of the innominate, left carotid, and left subclavian arteries to maintain blood flow.
Lining up holes and tubes from inside a moving aorta.
Exactly. While the heart is beating and the aorta is pulsating, it requires advanced imaging guidance and incredible precision. The aim, of course, is to offer a significantly less invasive option, particularly for patients who are considered too frail or too high risk for conventional open or even hybrid surgery.
What kind of anatomy do you absolutely need for this purely endovascular approach to even be possible?
The requirements for the landing zones where the ends of the main stent graft will seal are very strict. You need a stable, relatively healthy area for the graft to anchor. Preferably, this would be in a previous surgical graft if the patient had prior ascending aortic surgery, or in a native ascending aorta that's not too dilated again, generally less than 38 millimeters in diameter to minimize that risk of retrograde dissection.
Okay. And the landing zone needs to be long enough.
Yes, you need adequate length for sealing, typically at least 30 millimeters, and the area should have minimal calcium buildup or thrombus, which could prevent a good seal. Also, the angle of the aorta shouldn't be too sharp, usually less than 60 degrees angulation is preferred. So it's a select group of patients anatomically.
And what about the risk of stroke with this total endovascular approach? You mentioned it was a concern with hybrid, too.
Stroke remains a major concern, perhaps even more so with these complex total endovascular procedures. The document cites stroke rates in published series of up to 14%.
14%, that's quite high.
It is significant. It can happen if atherosclerotic debris gets dislodged from the aortic wall during the extensive catheter and wire manipulations in the arch, or if air gets introduced into the system through the large delivery devices. Teams are actively exploring techniques to try and mitigate this risk, things like temporarily blocking or filtering blood flow to the carotid arteries during deployment, or meticulously flushing devices with CO2 gas to remove air, but stroke prevention is still a major challenge.
So potentially much less invasive on the outside, but still carries significant internal risks, especially neurological ones. What are the formal recommendations for using this total endovascular approach?
It is considered a viable option, particularly for repairs involving zone 0, the proximal arc-ascending aorta, but mainly in patients deemed unfit for open surgery who do have suitable anatomy.
So primarily for high surgical risk patients for zone 0.
Generally, yes. For repairs mainly targeting zones 1 and 2, the more distal arch, it is also considered an option for patients with suitable anatomy, potentially including those who might otherwise be candidates for hybrid repair. The same strict landing zone rules apply. Landing zone length less than 25 millimeter or diameter greater than 38 millimeter is not recommended. And again, critically, using these devices with a landing zone in native aorta in patients with known connective tissue disease is not recommended. Class 3C, and like all these complex techniques, centralization to experienced centers is strongly recommended.
It sounds like incredible technology, pushing the boundaries, but with very specific limitations and significant risks still being worked out. Are there any other, maybe less preferred or more controversial endovascular techniques that the document mentions?
Yes, they discuss a few approaches that generally aren't the first choice. One is using parallel grafts, sometimes called chimneys or snorkels.
Chimneys? It's like stovepipes?
Sort of. It involves placing standard off-the-shelf stent grafts alongside the main aortic stent graft, extending up into the branch vessels, like the carotid or subclavian, to maintain flow to them when the main graft covers their origins.
So you just run smaller pipes next to the big one inside the aorta?
Essentially, yes. The major problem is that it's hard to get a perfect seal between these parallel grafts and the main graft. You often get leaks, called type I endoleaks, through the gaps or gutters between them. Plus, the currently available devices aren't really designed or approved for this specific application in the arch.
So it's kind of an improvised solution.
It often is. Therefore, this parallel graft approach is generally only considered in very urgent or emergent situations where custom-made branched or fenestrated grafts aren't available in time, or perhaps as a bailout maneuver if a critical vessel is accidentally covered during a standard TEVAR procedure. It is explicitly not recommended as a routine planned strategy if open surgery or purpose-built branched fenestrated grafts are viable options.
Okay, so really more of an emergency fix or last resort. What about the idea of making the holes for the branches during the procedure itself in a standard graft?
That's called in situ fenestration. This is a very new, highly advanced, and still largely investigational technique. It involves using lasers or special needles to create holes in a stand of TEVAR graft after it has already been deployed inside the aorta, and then stenting through those holes into the branch vessels.
Wow, customizing it on the fly inside the body.
Exactly. It's considered off-label, meaning the devices aren't approved for this use. There are concerns it could potentially damage the integrity of the graft material. Currently, it's really only being done in highly specialized centers as part of clinical studies, or perhaps as an emergent bailout technique when no other option exists. Definitely not standard practice.
Got it. Very experimental. And one more technique mentioned was using a mesh-like stent, the multi-layer technique.
Yes, this involved using a specific type of bare metal mesh stent, initially proposed to try and slow down or modulate blood flow within an aneurysm or dissection, theoretically promoting thrombosis and healing without completely blocking flow.
Did it work?
The evidence supporting this concept, especially in the complex flow environment of the aortic arch, has been very conflicted and generally underwhelming. The expert consensus document is quite clear and firm on this one. The multi-layer flow modulator stent technique is not recommended for treating any type of aortic arch pathology. That's a strong Class 3 recommendation.
Okay, so that one's off the table, according to these experts. It's fascinating to see the range of innovation, but also important to know which approaches have solid backing and which are still experimental or not supported. Beyond the major issues of aneurysms and dissections, the document also briefly touches on some less common problems that can affect the aortic arch.
It does, yeah. It covers a few rarer pathologies, for instance, aortic arch thrombus. This is where blood clots form directly on the wall of the arch or are floating within it.
Clots just forming in the main artery. That sounds incredibly dangerous for stroke risk.
Extremely dangerous. These clots, especially if they're mobile or floating, can easily break off, embolize, and travel straight up to the brain, causing devastating strokes. The guidelines state that surgical treatment should be considered for patients who have symptoms clearly linked to a floating thrombus in the arch.
And if the clot is just stuck to the wall?
For symptomatic clots that are just lining the wall, mural thrombi, especially if they're extensive, surgical treatment may be considered a weaker recommendation. The document also notes that these thrombi can sometimes be linked to underlying hypercoagulation disorders where the blood is too prone to clotting.
Okay. What about anatomical quirks people are born with?
They discuss two main ones, the aberrant subclavian artery and Comorhals diverticulum. An aberrant subclavian artery is usually the right subclavian artery arising last off the arch instead of first via the innominate and crossing behind the esophagus or trachea.
So it takes a weird path.
Exactly. A Comorhals diverticulum is a bulge or outpouching at the origin of such an aberrant artery. While most people with these variations have no symptoms, a small percentage can develop issues like difficulty swallowing, dysphagia lusoria, or breathing problems due to compression.
When do these need fixing?
The recommendation is that repair should be considered if the aberrant subclavian artery itself becomes aneurysmal, dilated over 3 centimeters, or if the Comorhals diverticulum becomes large, generally over 5.5 centimeters, because of the risk of rupture. Treatment usually involves surgically rerouting the vessel or sometimes using stent grafts combined with vessel closure.
So fixing the unusual anatomy if it's causing symptoms or poses a rupture risk, what about injuries from trauma?
Traumatic aortic injury, TAI, specifically affecting the arch can happen, usually from severe blunt chest trauma like high-speed car accidents. The most common site is actually just after the arch, the isthmus, but the arch itself can be involved. Severe injuries, like contained ruptures, pseudoaneurysms, or free ruptures, obviously require urgent repair. Endovascular repair, TEVAR, has become the preferred approach for most traumatic aortic injuries when anatomically feasible, as it's less invasive than open surgery in a potentially multi-injured patient.
Makes sense to go less invasive if possible after major trauma. And infection. Can the aorta itself get infected?
Yes, infection of the native aorta, or, more commonly, infection of a previously placed aortic graft infection, is a very serious, life-threatening complication. Diagnosis can be challenging and usually involves a combination of clinical signs, fever, pain, specific radiological findings on CT or PET scans, and lab data sometimes using scoring systems like the MAGIC criteria.
How do you treat an infected aorta or graft? That sounds incredibly difficult.
It is. Treatment often requires aggressive surgery to remove all the infected aortic tissue or graft material. Then the aorta needs to be reconstructed, often in situ, in the same place. The experts favor using biological materials for the reconstruction in an infected field, such as specially prepared animal pericardium, xenopericardial tubes, or cryopreserved human arteries, homografts, if available. This is considered the preferred approach.
So replace the infected artificial material with biological material.
Ideally, yes. Endovascular repair may be considered as a less invasive option, perhaps as a temporary bridge to definitive surgery, or even as a definitive treatment in patients who are simply too sick to survive a major open operation. But it must always be combined with aggressive, long-term antibiotic therapy, and the long-term success rates are still debated.
So infection really changes the whole treatment paradigm. Finally, the document mentions inflammatory aortic arch disease or vasculitis affecting the arch.
Right, specifically two main types, giant cell arteritis, GCA, and Takayasu's arteritis.
GCA affects older people.
Typically, yes. Often presents with sudden onset of inflammatory symptoms like headache, jaw pain when chewing, scalp tenderness, and sometimes visual disturbances. Crucially, it can involve the aorta in its major branches, including the arch, leading to aneurysms or dissections later on. There's also a significant risk of blindness if the temporal arteries are involved and not treated promptly. Prompt diagnosis, often involving temporal artery biopsy or imaging, and treatment with high-dose steroids and sometimes newer targeted therapies are crucial.
And Takayasu's. That's different.
Yes, Takayasu's arteritis typically affects younger women, often before age 40. It also causes inflammation of the aorta and its branches, but it more commonly leads to narrowing or stenosis of the vessels coming off the arch. This can cause symptoms like arm claudication, pain with use, dizziness, or stroke-like symptoms due to reduced blood flow, sometimes called the pulseless disease.
How is Takayasu's treated?
Diagnosis uses similar imaging modalities, CT, MRI, PAE, to assess the extent of inflammation and vessel damage. Treatment primarily involves immunosuppressive medications to control the inflammation. Surgical or endovascular repair, like stenting for the narrowed segments, might be needed later, but often only after the inflammation is well controlled, as procedures done during active inflammation tend to fail or restenoze quickly. Repairing dilated segments in Takayasu's is also challenging due to the ongoing disease process.
So for both of these inflammatory conditions, being aware of them, diagnosing them based on the patient profile and imaging, and treating the underlying inflammation medically is really the key first step.
Absolutely. The document advises suspicion of vasculitis in these specific patient groups and emphasizes that prompt medical treatment can prevent severe, irreversible complications like stroke, blindness, or aortic rupture.
Wow. This has been an incredibly comprehensive journey through a really challenging part of the cardiovascular system. We've covered the basic anatomy, the different types of diseases from aneurysms and dissections to rarer things like thrombi and vasculitis.
How they're diagnosed using advanced imaging, the whole complex decision-making process that relies on these specialized aortic teams.
The incredibly detailed monitoring required during procedures to protect the brain and spinal cord, and then this whole evolving range of treatment options, open surgery, the different hybrid approaches like VTT and debranching, and the cutting-edge total endovascular techniques.
It really highlights how far the field has come, offering more options than ever before, but also just how much complexity remains in managing these conditions effectively.
It really does.
Yeah.
And as you pointed out, and as the document itself acknowledges quite openly, for many of these recommendations, particularly for the newer techniques, the actual level of scientific evidence is still graded as C.
Right, which basically means it's based on expert consensus, case series, or smaller observational studies rather than large, definitive, randomized controlled trials.
Why is that? Why is the top-level evidence often lacking in this specific field?
Well, it's a combination of factors, really. These are relatively rare conditions compared to, say, coronary artery disease. The ways they present can vary hugely from patient to patient. Building up large caseloads to do big trials takes time and collaboration across many centers. And maybe most significantly, the technology, especially in the endovascular space, is evolving so incredibly rapidly. By the time a large multi-year trial comparing one technique to another is completed, the devices or even the techniques themselves might have already changed or been superseded. It's hard for the highest level of evidence generation to keep pace.
That makes sense. The field is moving almost too fast for the traditional research methods to keep up, which means, what's the takeaway from that?
It really points to the critical need for continued structured international collaboration, and perhaps even more importantly, the need for better standardized ways to report outcomes consistently across different centers and different techniques. We need robust registries that track not just immediate survival, but key functional outcomes like mortality rates over time, stroke rates, both major and minor, spinal cord injury rates, reintervention rates, and patient-reported quality of life. Only then can we really start to compare these different complex strategies fairly.
And the document itself actually lists specific areas where the experts feel more research is urgently needed. They call them key gaps in evidence.
They do, yeah. It's quite a list, actually. Improving our fundamental understanding of why stroke happens during these procedures and developing better methods to prevent it is clearly high on the list.
That makes sense given the stroke rates mentioned.
Absolutely. Also, determining the optimal treatment strategy for specific clinical scenarios like when is FET truly better than standard open? When is hybrid better than endo, or vice versa, for different types of dissections versus aneurysms in acute versus chronic settings? Refining imaging techniques even further to better predict risk or guide therapy. Understanding patient-reported outcomes, what actually matters most to patients long-term. Developing better ways to create and utilize clinical registries and measure the performance of aortic teams. How do we factor in things like patient frailty or potential gender differences in outcomes? Getting a much better handle on the specific genetic risks beyond just Marfan and LDS. Refining the surgical techniques themselves, like how much of the aorta really needs to be replaced in a type A dissection. And of course, continuing to clarify that controversial issue around the long-term durability and safety of using stent grafts, whether FET or TEVAR, in patients with connective tissue disease.
That's a pretty significant roadmap for future research, isn't it? It really underscores that despite all the advances, this field is still very much actively learning and refining its approach.
Precisely. While the expertise and the technology available are truly impressive, there's still a lot of foundational work and comparative effectiveness research that needs to be done.
So, to try and wrap things up for our listeners, the core message seems to be that successfully treating aortic arch disease is a highly specialized, complex endeavor. It absolutely relies on having a dedicated, multidisciplinary team approach, usually in a high-volume center. It requires precise diagnoses using the right advanced imaging tailored to the clinical situation. It involves very careful selection of the right treatment strategy, whether that's open, hybrid, or endovascular, based meticulously on the individual patient's anatomy, their specific pathology, and their overall risk profile. And it demands sophisticated multimodality monitoring during the procedure itself to protect those vital organs, especially the brain and spinal cord.
That sums it up well. It's a field marked by constant innovation and incredible technical skill, but one that still grapples with significant known complexities, risks, and many unanswered questions.
Which leads us to perhaps a final provocative thought for you to consider. Given the incredible speed of technological advancement that we've discussed, particularly in these less invasive endovascular techniques, and the understandable societal push towards less invasive options whenever possible, how do medical specialties, and indeed healthcare systems, ensure that these cutting-edge approaches are genuinely safer, more effective in the long run, and equitably accessible to the patients who might benefit most? Especially when, as we've seen, the foundational evidence for many of them is still actively being built, and the best outcomes currently seem so strongly linked to performing these procedures in highly specialized, high-volume centers.
That's a crucial question, isn't it? Balancing innovation with evidence, expertise, and access. It's central to the future of complex aortic care and many other areas of medicine, too.
Indeed it is. Well, thank you for joining us today for this incredibly detailed deep dive into the world of aortic arch diseases.
Thank you. It was a fascinating discussion.
Keep exploring, keep learning.